Thank you very much for that great presentation. The great panel here in terms of talking about a key issue of drug use and health literacy. So we have some time for discussion and questions, and this would be a good time for you to indicate that you have such questions and comments. So if you'll raise your, go ahead, Betsy. Please identify yourself too before you make your comment.
That one. I'm Betsy Humphreys from the National Library of Medicine. Great presentations by everyone, and it's interesting to see the history of this work. I was very intrigued, Terry, by some of the things that you were talking about. And first, I would like to say that the National Library of Medicine really appreciates all the collaboration we have with CDER and with FDA generally in terms of things like making the approved labels available through Daily Med and the collaboration that helps us keep the RX norm standard terminology for drugs up to date. But I was interested in this notion. It seems like such a great idea to have one patient handout. And I was running through in my head the cases where it would not be a good idea. I mean, if it was really a requirement. I mean, because I could imagine a scenario where for this patient, because they have other comorbidities or they have something else, they're supposed to do something else. Or because this is the normal dosing, but because somebody is really helping them and trying to give them a simpler dosing in all of their, in all of their other medications, that they're going to get some different instructions. And so I was thinking, it's a great idea, but if it was applied too rigorously, maybe it would actually end up, in some cases, not being a great idea. I wonder if you'd comment on that.
Thank you for that. I think with every great idea, there come stumbling blocks, but it's important to think ahead of time as to what those stumbling blocks might be and how you can address some of them. So some of the things that have already been talked through would be, when do you hand these out? Obviously, if you have a patient in the intensive care unit who's intubated, as many of my patients are, this PMI is not going to be very helpful to that patient. And the idea is not to be handing these out in hospitals, but to use them for pharmacies, where we're primarily handing out a whole variety of things that may be confusing. It's also not meant to replace the instructions for use that come with some of our medications that, for example, need additional guidance, like the meter dose inhalers, things that come with devices, or an auto injector. So that will still be there. The idea is just to have a standardized format. And certainly I'm sure that, if physicians are involved or pharmacists are involved, there's nothing to say that they can't write on there or do something different for an individual patient.
Go ahead.
The other thing, I think the idea of somehow being able to present information where it is statistically significant and exists on the demographic breakdown and is wonderful. And as I now know more about the both the strengths and the shortcomings of clinical trial design through our work with clinicaltrials.gov that I thought I would ever know, I am sure that the FDA would be aware that aggregating some of these data or putting them together in various ways, or even believing them, given the original power they wanted and the eventual number of patients they got and all these other factors, there's a lot to consider here. And the demographic breakdown data that actually exists may not be too accurate. So this is obviously going to have to be done with a lot of expertise in terms of where reliable data actually exist.
Thank you. I couldn't agree with you more. It's not very useful to report on a subgroup that's very tiny. As we all know as clinical researchers, that doesn't tell you a whole lot. So I've seen the proofs for some of these. It looks pretty good. So hopefully as we move forward, we'll get additional feedback from the field, from users who can say what's helpful, what's not helpful, and how can this information be best presented?
Betsy, can I just give one example of, I guess, a concern about the question you raised, will these be appropriate for all patients? And that's off-label uses. So there really hasn't been a good solution described by the agency of how that type of information will be applied. And I'll give an example. Methotrexate was used for many, many years to treat arthritis before it ever got approved by FDA for that. And imagine the patient who got a piece of PMI that only talked about cancer as the use for that particular drug. And so that really is an important issue. And for many drugs, off-label use is actually more common and more important than the labeled use of those drugs. So that's a big issue that needs to be addressed moving forward with this particular.
One other comment I would say is a part of the vision, I think, for the medication label specifically that is on the horizon, and something that we need to think about is the ideal, I really believe, is to figure out a way as we come up with a more standard approach to the instructions on the label, which is where the rubber meets the road for the actual individual, the patient. What we really want to see is that become a piece of the clinical trial that brings medications to market, so that the data from the trial actually reflect the reality of what it is that ends up on a label and what it is that ends up happening with the actual person consuming the products. So I think it's important, as we think about all the many pieces, to think about what it is we'd like to see happen and keep at the forefront the idea that the ultimate goal really is to be able to have the data that drives safe and effective use reflect the reality of the best approach we have for people who are taking medications. And of course, I can't help but add the ideal thing, which I always remind myself at the FDA, is to not need to take the medications.
Laurie?
Hi. Thanks to each of you for thought-provoking, wonderful presentations. My name is Laurie Myers, and I'm from Merck. And I actually have a question for Terry, which is, the PMI has been in the works for a number of years. Do you have any sense on the timing of the implementation of or timing of the framework and the implementation? And part two is, are there plans to include representation from patients with low health literacy as part of the consumer research? Thank you.
Right. So in terms of timing, I can't really tell you a whole lot other than to say we're working on it. In terms of low literacy, that's a key factor for us. And in the OTC world, we are always pushing very hard to ensure that all of our consumer studies reflect also a low literate population. And so for pharmaceutical companies that come in to talk to us, that's one of the first things that we mention. In the RX world, I'm sure when they begin to look at studies like this, if that initiative goes forward in that way, I'm sure that they will also be including that. We have a guidance out on how to do label comprehension studies that includes information about low literacy, and it would be very applicable to that sort of a thing as well.
Great, thank you. With respect to cell phones and smartphones and the popularity of those devices with people of all demographics, including those low literacy, I'm wondering whether the future of accurate drug labeling will, in a sense, have a way of an opportunity to use that technology or integrate with that technology in terms of reminders or in terms of prompts that would link or reinforce what's on the label. So I'm curious from each of you, think about, in a sense, the future of that technology relative to this topic. Does it have one? Are we thinking about it?
I'll just start off and say it would be hard for anything that is that pervasive in our society to not have a place here. And we're considering sort of all options as part of the Ensure initiative, and we've thrown it out to the pharmaceutical companies to see what creative things they can come up with. I was at an interesting conference last spring by the Consumer Healthcare Products Association, where there was a representative from a company that makes toothbrushes who described this very interesting app for your smartphone that you hooked up to your toothbrush that then gave you information about how your brushing habits were doing and whether you missed a spot on the right side or not. And it was really fascinating. People were liking this, and it was out there. So I'm sure that it will come.
So I spoke at the Roundtables on Disparities recently on sort of from the health literacy lens, and one of the comments there, because there were a lot of the tech folks at the table. It was a great meeting. But right now there are almost 700 different apps for taking your medications. I don't know how many of those you use, George, or have looked at. But it's kind of like when you go buy a bottle of ketchup when there are 27 bottles on the shelf. My husband always comes home with none because he's so captivated by how many there are. But so I don't know, like maybe, and there are some trials in the field, and I think there again we've got to figure out what works where and why, and it's thrown to the market right now, and there's a lot of interest. I'll also tell you that we do know that a lot of people, and especially some of the populations that are more underserved, really like their cell phone and use it a lot in texting. Mm-hmm. And it may be one of the good pathways for addressing some of the disparities that we know exist. I'll also tell you that some of us have been cited as potential members of HIPAA violations for using our cell phones for communicating with patients, especially about their medications, when we ask them to text us a picture of what they're taking, and our cell phone just became a piece of the medical record, and is it encrypted, and is there patient data, and is there access? So there's a lot to look at in the space as we move forward, but I think there probably is amazing opportunity.
And there are, I guess, federal reasons why that's very likely to occur. So the Office of the National Coordinator, the Meaningful Use Stage 2 requirements for EHRs require that there be patient access to information in context. So what that means is if a patient goes into their EHR portal using their phone, which is probably the most common place that people will access it, and they look at their medication list to get the certification for Stage 2, that EHR must provide the in-context access to information about that drug. So if the patient's looking at metformin on their list and they click on it, it should take them immediately to contextual information about the use of that drug. So that's already being adopted, and the government's stimulating it.
Other questions? Well, I have more. So thinking about the definition of health literacy, the degree to which individuals have the capacity to obtain, process, and understand basic health information, and the services needed to make appropriate health decisions, and the over-the-counter drug labeling issues that you raised. It seems to me that in terms of self-diagnosing minor illness and going to the drugstore and buying drugs, it's quite a challenge. I mean, to figure out, one, what you want to take, and then two, to find it on the shelves, let alone look at the individual bottles and understand the directions. And again, it seems to me that there's a opportunity there to look at the issue of drug labeling and integrate it with a larger system of aids to help people make those decisions. Any thoughts about how this topic of drug labeling for over-the-counter drugs might integrate with a larger system for helping the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions? Any comments on that?
That's a tall order.
This is also about the future, this conversation.
So, where do we go beyond the drug facts label?
Mm-hmm.
And I think OTC consumers get their information in a whole variety of different ways, and we need to reach out to them beyond just what's on the pharmacy shelf. So FDA has a variety of different communication options. We are reaching out with drug safety communications. We're reaching out. We have a nifty little program called Medications in Your House that reaches out not only to the adult consumer, but also has a opportunity to use it as a middle school curriculum so that our budding adults and our soon-to-become consumers can understand, what's that in my pharmacy shelf and what's that in my medicine cabinet that I need to know about, and recognize that there is information there that they should be accessing. So I think we need to be very creative in this space. It's not just about what's on that drug facts label, although I think that's, kind of the fundamental piece. One of the things that I learned coming to the OTC space, when you're in the prescription world, it's all about the package insert, and we control that very tightly, and the advertising flows from that, and so on and so forth. But in the OTC space, the drug facts label is just a small part of what the consumer sees. They actually see, first off, what's on the face of the box. Does it tell you what the name of the drug is? You'd be surprised how many of them don't. And what advertising is on that box. We need to look at those things and make sure that we are not giving wrong information to the patient. So I think those are just a few of the things that we're thinking about already, and I'm sure there are many more. And we look to groups such as this with your health literacy hats on to help us make those decisions and guidance for the future.
Ruth?
I'll just make one comment that's probably not the answer you expected, but I'll tell you that as a healthcare practitioner, my own health literacy has really been advanced by being a part of FDA advisories. I first met Alistair Wood there. He was chairing NDAC, the non-prescription drug advisory, when I met him. And as we moved forward, he set forward the idea about the universal medication schedule and became very engaged in it. And I think certainly the FDA and the fact that it's a regulatory agency, and boy, it's been an education to see the nuances of a regulatory agency of the most powerful country in the world and what's under it. But I think their willingness to have those of us who are engaged in this field be a part of their conversations, to become educated and health literate ourselves about the nuances of a regulatory agency and what it takes to make progress and what to change, has really contributed certainly to my lens of what it's about. So I'm very appreciative of their allowing us to be a part of the table, and I think there's great room for engagement. And as I speak to my colleagues who are part of the manufacturing world, who I think are critical to moving labels and health literacy forward, I've commented to them that you really don't want a regulatory agency that moves too quickly, because we're a big country and we're very nuanced. So I appreciate what I've learned at the table with them.
A simple example, I think, that's not so simple to solve is just the identity that the patient associates with a product. And discussions are ongoing right now on the branding of products where the original brand that the patient may associate with a given product is then applied to a whole number of other products. So I'll use Sudafed as an example. When the drug itself had to go behind the counter because of the pseudoephedrine abuse potential, they branded an equivalent product in the sense something that could also be used with phenylephrine as Sudafed PE. And there are other examples where you will see a branding that gets applied to a number of products. And again, it may not seem important, but it really is. Patients will draw their conclusions about what that product is intended for because of the history that they have with that brand. And that's some discussion that's ongoing right now, is how do we balance the importance to the manufacturer of the brand versus solving that particular issue. And acetaminophen is another example. We're the only country in the world where that is the generic name for that drug. Every other country in the world, it's paracetamol. And with the large number of immigrants that we have in this country, it's important that acetaminophen also be identified as paracetamol, because someone from Central America will not recognize it as being acetaminophen, and potentially could be overdosing on products that contain a drug that they're not familiar with.
So I want to thank this panel. This discussion has illustrated a couple of things. One, we have some very capable individuals who are addressing the issues. I want to thank each of you for talking to this issue. Secondly, it illustrates the fact that this is an illustration of the complexity of the interface of medications with our need to treat ourselves and to keep healthy. I mean, if there's I can't imagine a topic that illustrates the complexity of doing this right as taking drugs, completely and well. It also illustrates, one, the amount of progress that we've made, and draws at least a clear line to some of the activities of this roundtable and some of that progress. And then lastly, I think it only scratches the surface with the progress we need to make in order to solve this issue. And so I'm very encouraged that we've got the opportunity to do that as a roundtable. So with that, I want to please thank this panel.